everyone is settled, we'll get started with the presentation. Just want to make sure everyone can hear us in telehealth land. Okay, perfect. And just a reminder to make sure that your microphone is muted. So we're here for the second last day of Blood Management Awareness Week. And we have Dr. Marko from DSM here to present on hemolytic disease of the newborn. So I will pass it over to him.
All right, thank you for that lovely presentation or introduction. All right, today we will be talking about an overview of hemolytic disease of the newborn. I'm being filmed, so if I'm looking at the camera, then you'll know. And if you think I'm ignoring you, I apologize. All right. It's awfully small. Oh, okay. So, what on earth is hemolytic disease of the newborn? Essentially, it's really easy. All it is antibodies from the mother to antigens on the surface of the red cells of the baby. Pathophysiology, just a little out of focus. So, essentially what happens is there's some fetal maternal hemorrhage exposing antigens from the baby, and the mom sees it and produces antibodies. For the RH group, essentially around week 16, the baby starts to produce the RH antigen, and then at least by week 17, the mother starts to produce the receptor, the FC receptors for the IVIG. So disease can start taking place by week 18 through 20. So the mother sees this foreign antigen, produces the antibody. Antibody sticks to the red cells, but RH antigen cannot affix complement. So it goes to the spleen. The spleen clears it via the macrophages, and everything's happy, except for you get a lot of hemolysis. As a result of all the hemolysis, the bone marrow starts to rev up the production of red cells. More and more and more and more. Oh, are you okay? Have you fallen? Oh no. Security. Anyhow, where was I? I've lost train of thought. In the spleen, in the spleen, actually we were in the bone marrow. Yeah. So the bone marrow's revving up the production of all these red cells, and then there's no place for the other hematopoietic elements to grow and flourish. So you get extra medullary hematopoiesis. This can occur in the liver. Occurs in the liver, what happens is decreased production of stuff that the liver produces, such as albumin. And when that happens, you have a decrease in oncotic pressure. And so if this is albumin, you essentially rush in fluid from the extravascular spaces into the vascular spaces. So if you decrease that, you now are able to shoot the fluid out into the intracellular spaces. What happens in that situation, all this fluid now drains back into the lymphatic system, and the lymphatic system goes back into the circulation. And so if you have more fluid coming back into the circulation, now at the same time you're having a lot of hydrostatic pressure in the vasculature, well, this is going to amplify. And so the end stage is a lot of edema and the heart having to pump out a lot of fluid. So you get high output failure. So that is the end consequence, and this is the thing that we want to avoid, the hydrops fecalis. That's the bad thing that we have to avoid. That's the endpoint due to all this extra fluid. So there is there is another problem. If you are having a lot of hemolysis, you're producing a lot of bilirubin. And the bilirubin needs to be eliminated because it can be quite toxic. So when the kid is in the mom, the bilirubin is unconjugated, but goes to the mother's liver and then is conjugated through that way. So it's not, the bilirubin is not too much of a problem when the kid is in the mother. It's after birth. Then you have problems. So does this make sort of sense? So the endpoint is all this edema, all this extra fluid, all of the heart needing to sort of overcome all this extra fluid, and then just giving out, and you get a high output failure. This is the, some of these photos will be graphic, so just close your eyes. So again, this is the endpoint that you want to avoid. Essentially, oncotic pressures decrease, causing all this increased hydrostatic pressure and the amplification of all this fluid, leading to high output cardiac failure.
Sorry everyone.
I'm sorry for people off site, but people are falling several times. Oh. And if you do that, I will call you out too. I'm sorry. So there are various flavors of high drops. Immune high drops is what I just talked about, but note that you're going to have high drops due to anemia. The most common cause is thalassemia. You're going to have it due to infection. Parvovirus is probably top of the list. But other causes as well, from chromosomal abnormalities to congenital nephrotic syndrome, many other ones. Kernicterus is when you have all this bilirubin. So I said there's no problem before birth because the mother is taking care of all this bilirubin. She can conjugate the bilirubin in her liver. Now, once birth takes place, the baby's on their own. They've got to now take care of all this bilirubin. And they can't really conjugate it. So guess what happens? It accumulates. It accumulates into all parts of the body, including the brain. And you get these permanent problems associated with it. So this is what needs to be avoided after birth. What happens, what you want to avoid before birth is the high drops. You want to try to stop them any way you can. What happens after birth is the bilirubin situation. Just briefly goes over what I just said about the bilirubin. So, hemorrhage. The hemorrhage can be as little as 0.1 to around 1 mil of blood, red blood cells, and the most of this is caused by delivery, but other things from trauma to membrane rupture can also lead to this fetal membrane hemorrhage. So this is good statistics. So without prophylaxis, alloimmunization is 16% of the D-negative mothers, which 2% are sensitized in the first pregnancy, so it can happen in the first pregnancy. 7% within 6 months, 7% during the second pregnancy, and if you have a history of anti-D, 10%. So overall, of the 16%, 10% chance of high drops. Now this is without RhoGAM or WinRho. Now, if you've had high drops before, unfortunately, you have a 90% chance of getting high drops subsequent to pregnancy. Etiology. ABO. ABO is the most common cause of HDN. Of those, the most common antibody is anti-A, B, which is IgG. but you're going to have also IVIG, anti-B, anti-A. And unlike the RH, can happen in the first pregnancy because early on in life, you're exposed to A just through gut flora, or B, and you produced antibodies early on. These are usually mild disease. RH, on the other hand, usually can be quite severe. D is more severe than small c, is more severe than big E. But any other antigen can give you HDN, well, these ones, but they're usually mild. And just a note about the KEL, remember I said there was a problem with bilirubin with the D, but with the KEL, the situation is a little different because the antibodies attack the immature erythroblasts in the bone marrow. So this is before hemoglobin is incorporated. So since bilirubin's from hemoglobin, the breakdown product, we don't have a bilirubin problem because the antibody, anti-KEL1, is attacking the erythroblasts. And so you've eliminated the later stage that has the bilirubin. Prenatal evaluation. So serological testing on the mother, treat just routine test essentially. You do the ABO, RH test, do antibody screen, and antibody ID. You guys thought I was leaving, didn't you? For a minute there I thought, well, what if I just started walking? It just kept walking. I did think that, and you thought that too. What is he doing? It's very strange. Never had it. So if the antibody screen is positive, you want to do a antibody panel. Once you've identified an alloantibody, you now want to do titers on it. And place to place will have different cutoff points and when to start. But essentially you want to follow at some intervals those titers. This is how to do the titer. Essentially, you have some test red blood cells, mix it with plasma, you need to do a 1:2, 1:4 dilutions. Which red cells to use? The most common one is the R2, the one with the big D, big E, versus R1, small r. The reason they do R2 is because this has more antigenic response. It's stronger antigen expression. So there are these places, like where I trained in Iowa, that were obsessed with this Marsh score. Because people read this paper here that emphasized not only should you be doing the titer, but you have to grade those titers as well. And somehow the OB people in certain institutions thought they got more value out of this. So luckily we don't do it here, but essentially not only do you do the dilutions, but you give the reactivity a score. So if it's a 3+, it would be equal to 10, and you have to add these up, which requires math. Believe me, I am not good. I have to still count on my fingers. Anyone else have to count? Everyone counts. Okay. You should think about also testing the father. Now, you could test the father serologically, but you don't get the story of zygosity. However, the antibody panel usually does give you whether it's homozygous or heterozygous, but you can't really say too much about the D. Now, you can also do molecular DNA amplification techniques, but obviously more expensive. You could also test the fetus itself, either do risky procedure called amniocentesis, or you can actually look for the fetal free DNA from the mother's serum or plasma. So response to the rising or critical titers, one of the things that is very non-invasive and actually correlates quite good to the fetal hematocrit and amniocentesis is to do Doppler by looking at the middle cerebral artery. And you want to see the velocity. So this, don't ask me to translate this picture, but apparently there's something there. So I've never read one myself, but there is a good correlation between what the amniocentesis can show you. And it's non-invasive. Ultrasound can give you some information about the placenta. So you're looking at thickness of the placenta, thickness of the umbilical vein. You can also, if the baby is very swollen, you can look for hydrops as well. Amniocentesis, here's a picture of amniocentesis, obviously a little more invasive. You're sticking a needle right in the amniotic sac. So what you do from this is you suck out the fluid and you want to measure the bilirubin. But you just don't measure the bilirubin directly. Nothing's that easy. What you have to do is you have to do spectrophotometry, where you get some absorbance or optical density from the patient, and you compare that to a standard curve. So here are the wavelengths. You want to look at 450 nanometers. This solid blue line, well, they're both solid, but the bottom blue line is the standard. The curvy blue line represents the patient. So all you do is take the difference between the patient and the standard curve at 450, and you look at the delta, or the change in optical density. From the change in optical density, you then will plot it to what's called the Lilly graph, named after someone. Maybe named Lilly, I don't know. Anyhow, from that information you want to, there are these zones, lower zone, mid zone, upper zone. Lower zone is not a big deal, unaffected fetus, versus upper zone, very, very severe. This is very, very critical. Here's the Lilly graph here. Here's zone 3 here, zone 2, zone 1. Here's the standard curve in red, in black. Here is the change in optical density for the patient, and you can see where it is in zone 3. So in this situation, it is very, very critical. Hubs, or pericutaneous umbilical sampling, is you actually stick a needle in the umbilical vein. Oof. Now, if you've seen me shake up here, and my hand's not steady, could you imagine me doing something like this? This takes quite a bit of skill. So it's very, very delicate, because you got to stick the needle in the umbilical vein. But you do get quite a bit of information. You can see if there's hemolysis, you can anemia, you can check DHE, hemoglobin, bilirubin, but the downside is it's quite risky. Prenatal management. So now you have severe, worrisome titers, very worrisome. Now what do? Well, you could give IVIG to the mother, or you can consider transfusions, intrauterine transfusions, and or you could start thinking about delivery. So what to do before the birth, so this is before the birth. Intrauterine transfusions is done if the amniotic fluid, the change or the delta OD, optical density, is in zone 2 or 3, or the chorecentesis shows a bilirubin or hemoglobin of less than 100, or on ultrasound there is evidence of hydrops. Oh. So there's actually a mathematical equation. This actually is more than addition, so I would defer this to someone who can actually do division. So anyhow, a lot of this information is derived from ultrasound, so obviously you wouldn't have this information available to you. So essentially you take the fetal weight times the placental and fetal total blood volume, which is estimated average of 0.14. Then you take the hematocrit. The hematocrit is in percent here. You take the desired hematocrit minus your hematocrit now, and divided by the hematocrit of the red cell unit, 85. What this information tells you is that you need 42 mils to be transfused to raise the hematocrit 25%. Make sense? So a lot of this information you would have to seek, or someone else could calculate it for you. Neonatal management. So birth has occurred. Now the baby is there, and like, what are you going to do? So now you're not worried about high drops. You're not worried about high drops now. This is before the birth, you're worried about high drops. Now you have to think about the bilirubin situation, and you want to prevent the bilirubin from sticking to parts of the brain that it shouldn't be sticking to. So there's a stepladder approach to intervention. First of all, look and see if there are any risk factors. Then stepwise phototherapy, IVIG, exchange transfusions should be considered. The indications for phototherapy, essentially what they're doing is they're looking at the risk, the gestational age, and the time after birth, and the total bilirubin of those times. And they're putting them into little categories, low risk or high risk, and from these numbers represent when you should start phototherapy. Indications for IVIG, so this is the next step. Essentially the same criteria you're looking at, but notice the numbers are a little higher there. Oops, where did I be? Oh, so IVIG, the phototherapy is not working, do IVIG. If that's not working, proceed on to exchange transfusion. So postpartum testing, obviously you're not going to be testing on the mother anymore, you're going to be testing on the child. And so you do ABO, RH, and the DAT. Note that if there was a lot of hemolysis going on, your DAT will be negative. DAT is just a test to see if there are any antibodies on the surface of the red cell, but if your red cells are all blown up, you're going to have a negative DAT. Prevention, think Winrow or Rogam, essentially fooling the mom into thinking that she has an antibody so she won't rev up a response to this foreign antigen. Oops. Usually starts at 28 weeks, or if there is some other event that is being done to the mother. Essentially, any of these things you should consider giving Rogam or Winrow. This is the typical vials. Here we have the 300 microgram or 1,500 IUs, which covers 30 mils of whole blood. 30 mils of whole blood. To determine how much to give, first determine if there was a fetal maternal hemorrhage. If you know that, if you know the fetal hemorrhage, the volume of bleed, and you may not know, you just divide it by 30 because it covers the 30 mils. First thing is the Rosette test, which gives you a qualitative, so a yay, nay answer for whether there is hemorrhage or not. Essentially, all you do is take reagent anti-D. So the pink here represents the fetal red blood cells. The maternal red cells are the dark red. So you give you put in anti-D reagent. The anti-D will bind to the kid's Rh antigens. You then put in reagent Rh positive red blood cells, so you get this little rosette-like structure. Hence, the Rosette test. It's not clever. No one cares. No one cares at all. Everyone's nodding. People in TV land, everyone's nodding. They're not amused at that joke at all. So, Klein-Howard-Becky, the acid Ellucian test gives you a quantitative answer. How much is there destruction? So what happens is you throw in some acid. The acid will destroy the adult hemoglobin, but leave the fetal hemoglobin here in pink. So you get the white represents adult red cells, and the pink represents the fetal red cells. This is what a real picture looks like. You can see the fetal versus, what do you think this is? 5 different answers. How is that possible? There's not. Yes, maternal. So you essentially just do another math equation. Quite advanced math for me. And I actually still use a calculator. Does anyone use calculators anymore? Or people just know? Oh, you have one right there. Oh.
Cell phone.
Oh, the cell phone. People use it on their cell phone now, do they?
Yeah.
Oh, wow. Who would have known? Cell phone has a calculator. Okay, some places are not doing the acid Ellucian. They've opted to more advanced flow cytometry, which essentially gives you the same answer as the KB. So how on earth, this requires more math, but there's an easier formula. So this is how much should you give? What dose of RhoGAM should you give? So first you have to determine the fetal bleed in milliliters. So the third line down, and you get you take the fetal bleed, or the fetal maternal red cells that you got from the KB, times it by the maternal blood volume, and then from the fetal bleed you have to divide by 30. And from that you get the dose of RhoGAM. However, now it gets a little strange because now you have these decimal points and you have to know when to round up one whole number or when to round up 2 whole numbers. So this 1, 2, 3, 4, 5, the 5th line down describes when you would increase it by 1. So if your dose of RhoGAM was 2.3, this 3 actually rounds down to a 0, and you add it by 1. So you get 3 vials. Got it? Isn't that not logical? So if it's greater than 0.5, so 2.6, 2.6 is greater than 2.5, you have to round up to 3. Then add another one. So 4 vials. You have to twist your head a little bit for that, but that's not that bad. So there was a resident. Does anyone know about BB Guy? BB Guy? Very good. BB Guy. Shout out to BB Guy. He gives these great lectures online. And one of his former residents was this math person who could do calculations in their head. So he came up with this math equation where determining the dose of ROCAM, where all you do is take the KB percentage. You don't change it to a decimal. You keep it as the percentage. Then you times by 5, divide by 3. That's the number of vials. Much, much easier. Much, much easier. So the KB percentage, full stop. Don't try to convert it to the decimal. Times 5 divided by 3. There's no real thought. So I really like this equation. Because you know me in math by now. So here's some considerations. If the mother has anti-D, ROGAM's not going to help out. And note that the ROGAMs can stay in the circulation for up to 6 months. So when you're doing your panel, you may see a D, anti-D, and you're thinking, oh no, they're anti-D. But no, clinical history is important. Has the mother or the patient been given ROGAM in the past? The end.
Do we have any questions here in the audience or in telehealth? Oh yeah, go ahead.
You had comments about after being born that IVIG after phototherapy.
After phototherapy, the next step would be IVIG.
Keep tapping that to help. What does it do?
Well, IVIG is a great trigger.
It's used for everything. Yeah, talk to the telehealth audience, please.
So the question was, in the treatment regimen, IVIG is used after phototherapy and before the exchange transfusion. And that's a very good question. So as we know, IVIG will trick the person not to produce antibody. So